Thank you, Manpreet, for this wonderful course and for making me a part of it. I would be talking to you about LASIK flaps gone astray. There are no financial or proprietary interests, and the flaps could be after microkeratome LASIK or femtosecond LASIK both. And you can have problems such as buttonhole flaps such as this, and these are the buttonhole flaps after microkeratome LASIK. So once you have this, it is best to put it back again and to irrigate it with the help of the fluid and put a bandage contact lens on it. This is the second one where the buttonhole flap is present right in the center here. So again, you have to just put it back in position. And this is the third one, which is a post-PK LASIK, where there's a Z-shaped buttonhole flap. And in these cases, it occurs more because the corneas are really steep. Now, then you can have a thin irregular, or whenever you have a thin irregular or buttonhole flap, you have to defer the surgery and recut after 3 months. If the refractive error allows you, you can do subepithelial PRK. But if it doesn't, then you will have to recut at a deeper plane and a larger flap if you're using a microkeratome, and a smaller one at a deeper cut if you're using a femtosecond laser. Then sometimes you can have epithelial ingrowth in these buttonhole flaps, which have to be addressed by PRK. And microkeratome jamming can be caused by motor jamming, suction loss, drape slashes, loose epithelium, and precipitated salt of irrigating solution. And whenever there is a torn flap, then you have to see at what level the tear is present. If it is peripheral, you can proceed with the ablation after protecting the hinge. If it is mid-peripheral or central, then one has to deposit the flap back and recut at a larger diameter and at a greater depth. So this is a case in which there was a tear which was present in the periphery, so one could still do the laser and then put the flap back. The only thing is, in the post-op period, one has to be careful that there is no epithelial ingrowth from the area of the tear, and also that there is no diffuse lamellar keratitis, which can occur in these cases more as compared to the other cases. Then you can have a dislodged flap also, such as this. Now, in very flat corneas, you can have free caps. And if the free cap is lost, then allow for central epithelialization and defer surgery so that there's some refractive stability. But if it is retrievable and it is greater than the size of the optic zone, then one can laser and reposit the flap back, and it may require additional amount of suturing, or you can leave it like this depending upon the degree of edema of the flap. But if the free cap is less than the optical zone size, then one has to defer surgery. So this is a case in which there was a free cap which was present. So the laser ablation was still done. The free cap was retrieved and it was placed in position. And because the earlier marks are already present, so basically what you have to do is align them into the previous marks and then subsequently place a bandage contact lens over it. I like to place it in the reverse manner because it kind of gives a better fit rather than putting it in the correct side up. Then this is our publication, Refractive Outcomes of LASIK After Flap Complications, and we didn't find any difference in terms of the visual acuity between the two groups where complications occur and where they did not occur. Then in cases of RK flaps, these incisions may just give way, and there may be separation of these incisions as you are putting the flap back. But these cases also can be ablated and the flap can be put back, again taking care that there's no epithelial ingrowth through the RK incisions. And this is our publication on LASIK for refractive errors following RK. Then complications can occur with femtosecond laser flap also, and such as in this case, notice that there's an opaque bubble layer, plus there are air bubbles which are present in the anterior chamber. So in these cases, what is done is that you can put the tracker off and you can still go ahead and do the laser ablation because it will take time for the bubbles to disappear. Then there can be vertical gas breakthrough such as this. And in these cases, it is best to plan the surgery at a later date. So one can see that there's a opaque bubble layer and a vertical gas breakthrough which is occurring. When the suction breaks, then you can have an incomplete flap. The lamellar bed treatment, if it has been completed and no side cut, then the procedure can be completed immediately. But if it occurs while making the side cut, then don't lift the flap and retreat later with a smaller flap at a greater depth. And the surface ablation can be done rarely if your refractive error allows you. Now, this was a case in which there was suction loss, and the surgeon still went ahead with the creation of the flap, which should not have been done because the suction is already lost. And once you do that, you will have a flap which is oval, and then subsequently a repeat surgery was done 3 months later, so that now the flap is of correct dimension and correct morphology, and this is then elevated, followed by the laser ablation, and then putting the flap back. Now, this is the same case in the post-op period, so you will have these two peripheral spindle will be present because of the previous flap and the flap which has now been created. This OBL I have already talked about. Ever since the hinge size has been decreased, the chances of this has become much less. This is a OBL which is present, and sometimes you can get away with this OBL also and do the laser ablation because the part of the pupil is still clear and it doesn't significantly affect your visual results. Then there can be micro adhesions or adhesions, especially when you're doing thin flap, then it may not, the adhesions may not separate very easily. So you put a blob of fluid over there, and once you put the fluid, then it will separate in a more amicable manner. So to conclude, the complications do occur after microkeratoma and femtosecond LASIK, but they should be diagnosed timely and managed appropriately. Thank you very much for your kind attention.
Thank you, Dr. Namrata, for showing a wonderful videos which are not seen nowadays much often. Just one query, in femtosecond laser we do have some unique complications like intracameral bubble, or you have anterior breakthrough. Do you had some instances like that, and how are those managed?
So if you have air bubble in the anterior chamber, then it is best to put the tracker off and still go ahead with the ablation, because the air bubbles will take a lot of time to disappear and your tracker will not track because the pupil is not going to be absolutely black in color. And in case there is a breakthrough, then it is best to not complete the procedure, and in case you have even completed the flap, it is best to defer the surgery to a later date.
Same like a buttonhole, Thank you, Namrata, for a wonderful